Are we good to start? Or
Hello, everyone. Hearty welcome to the 81st session in our 5th year of Learn from the Legends International Webinar Series. As usual, we have another true legend who has done a lot of work in this field, Professor Bonny B. Jasani from Canada, who would be talking to us today about one of the issues that's a nightmare for most of us at some point of our career or the other. PPHN. What are the physiologic principles and management of nitric oxide resistant PPHN? To moderate today's session, we have Dr. Rahul Kadam. He is a senior consultant neonatologist from Vijayapura, Karnataka, and Dr. Anita Singh. She is an additional professor in neonatology from Lucknow, India. Hearty welcome, all three of you. May I request the moderators to kindly take over the session.
Thank you very much, Manoj sir. I welcome you all and good morning, good evening and good afternoon as per your respective time zone. Today we have Dr. Bonny B. Jasani for our Learn from Legend series, and he is a staff neonatologist at Singh Hospital from University of Toronto at Canada. He has done his graduation from none other than India in the KG Somaya Hospital, followed by his DM Neonatology at KM Hospital. He has also done the fellowship in neonatal perinatal medicine and neonatal hemodynamics. His special interest is hemodynamics, and he has got the Teacher Excellence Award in neonatal perinatal medicine specialty. His special area of interest is management of PDA and mostly the neonatal hemodynamics part. So I would like to request Dr. Rahul to proceed further regarding the introduction of the topic of the today.
yeah. Thank you, Dr. Anita. Thank you, Dr. Manoj, for inviting us to moderate the session. Very good evening to those who are in India, and a very warm welcome to Dr. Bonny. As all of us know, PPHN is a syndrome which is associated with various underlying conditions, and there are different pathophysiologic mechanisms. And in around 30 to 40% of the cases, it may be refractory to nitric oxide at a conventional doses. And unfortunately, most of these cases are not the ideal candidates for ECMO. Say few of them may be preterm, few of them may not have ECMO available. So we need to have some rational pathophysiologic based algorithm to tackle with this PPHN. So today, Dr. Bonny will enlighten us about the pathophysiological principles and the management of iNO resistant pulmonary hypertension. I request participants to put their questions in the QA box, and over to you, Dr. Bonny.
Thank you for the kind introduction, Dr. Anita, Dr. Manoj, for inviting me to this phenomenal education international webinar series. And thank you, Rahul, for opening up the stage. So as we discussed earlier, I'm going to talk about inhaled nitric oxide resistant pulmonary hypertension in neonates and looking at the approach from bench to bedside. I don't have any financial relationships with the industry to disclose or conflict of interest to resolve. My talk would be addressing what is the pathophysiology of iNO resistance. We have all encountered these cases time and again, and how do we identify them early so that we can institute the right therapy at the right time with the right drugs. We would also look at what are the key determinants of pulmonary artery pressure, and we'll look at echo and clinical phenotypes and look at some interesting case scenarios and how to manage them. Moving on from the management perspective, we will look at the respiratory management, which is the key initial step in managing these really sick babies. And the favorite part of my talk, and I would really encourage all the trainees to look forward the aspect of pulmonary vasodilator therapy beyond iNO, and then key summary and conclusions. So acute pulmonary hypertension of the neonates, it's a big spectrum, as Rahul said, and You could have the acute PPHN in term, late, preterm, and post-term neonates due to poor transition, which is commonly seen in perinatal asphyxia, pneumonia, meconium aspiration, respiratory distress syndrome. You could have congenital diaphragmatic hernia, which can lead both to acute pulmonary hypertension as well as chronic. More and so, as we are moving our age of viability from 24 to 23 to 22, we are seeing acute early pulmonary hypertension in extremely preterm infants, specifically in the scenario of prolonged preterm rupture of membranes. And with the oligohydramnios, there is pulmonary hypoplasia, and these babies present with PPHN physiology. And lastly, survival of these extreme preterms as they grow older, we are seeing this phenotype of chronic late pulmonary hypertension associated with BPD, which is known either as BPD-PH or chronic PH. And a unique complication which can happen in some extreme preterm babies could be pulmonary vein stenosis, which is very difficult to manage but can lead to PPHN also. So how does inhaled nitric oxide? I'll jump in right away and I won't be delving into the common aspects of PPHN. Nitric oxide has dual mechanism. It has selective vasodilator effect, which is extra pulmonary. And there's no systemic vasodilatation because it is delivered right at the target site. Why does not have systemic vasodilatation? Because it's inactivated by combining with hemoglobin and it forms methemoglobin and it's deactivated. And also it has a microselective action at the alveolar level where it enters preferentially into the ventilated alveolus. And that's the reason we always say A and B always come before you start other fancy therapeutics. So always try to recruit your lungs, get your alveoli to the FRC level. And so it can lead to local vasodilatation of the neighboring pulmonary vessels, which are constricted and which can improve the VQ mismatch and also improve the intrapulmonary shunting. Transient improvement in oxygenation after starting iNO does not confirm PPHN, and it is a diagnosis. Although there are a lot of surrogate markers, the diagnosis can only be confirmed on echocardiography. But I would like to address this key principle that not all acute pulmonary hypertension at birth is PPHN. Pulmonary artery pressure is a product of pulmonary vascular resistance, which is the pressure in the pulmonary artery, main pulmonary artery, and which is the key determinant for causing increased pulmonary artery pressure, which can lead to PPHN. This is classically seen in disorders of transition like meconium aspiration, HIE, and it is pressure driven. So I use this hose analogy so that you can integrate this concept that PVR driven increase in pulmonary artery pressure is pressure driven. Secondly, there is increased pulmonary blood flow. This is a rare mechanism. You could see this. There could be increased flow secondary to large AVM either in the brain or elsewhere in the body or due to unobstructed TAPVD. This mechanism is flow driven. And lastly, you could have back pressure in the pulmonary veins, increased pulmonary capillary wedge pressure. And this is infrequent cause, but we do see some cases of isolated LV dysfunction, which can increase your LA pressure, and the LA pressure can be transmitted to your pulmonary veins. And this could be seen in some congenital heart disease like obstructed TAPVD, HLHS, multiple stenosis, or isolated LV dysfunction. So this is post-capillary in nature. So what leads to iron resistance and how can we optimize the effect of iron? So here we are looking at the heart-lung interaction, and the first key step is to have access to target pulmonary artery smooth muscle cell, and hence the first step is lung recruitment. You need to have optimal mean airway pressure. You need to distend your alveoli by delivering surfactant in disorders where there is surfactant deficiency or inhibition or secondary surfactant deficiency. And this has been well proven in the trial by Gonzalez et al., where in meconium aspiration syndrome or in pneumonia, where you have asymmetric lung disease, you could either have surfactant deficiency or consumption, and you could have one alveoli which is over distended and one alveoli which is collapsed. Both can lead to increased PVR. What nitric oxide does without lung recruitment or surfactant, it can only have the microselective effect at the local level and cause pulmonary vasodilatation, but it might not have a global effect, improving your extrapulmonary shunting and reducing that. So the trial by Gonzalez, which we'll talk about it later, so in specific cases such as pneumonia, RDS, meconium aspiration, lung recruitment followed by surfactant replacement, and then followed by iNO can lead to sustained and marked improvement in oxygenation, can lead to homogeneous lung expansion, and get your alveoli and your lung to the functional residual capacity, and you would have normoxic normal PaO2s leading to pulmonary vasodilation, all leading to decreased PVR. Secondly, we always in neonatal medicine, we are always kind of balancing what's the optimal FiO2 and what's the optimal PaO2 to be delivered, and we don't want to tilt this balance and cause harm. O2 and iNO is a marriage made in heaven or hell. Thanks to Satyan for this beautiful slide. O2 is a powerful vasodilator, and nitric oxide also causes vasodilatation of the pulmonary circuit. And O2 can lead to oxygen-induced free radicals, which can combine with nitric oxide to form peroxynitrite, which is a potent free derived free radical, which can cause pulmonary vasoconstriction. So too much oxygen is also harmful, and so you always have to titrate oxygen in these cases. Target SATs between 90 to 97%, never beyond that, and keep titrating oxygen so you don't have rebound pulmonary vasoconstriction due to formation of free radicals. So there is this delicate balance between SpO2, PaO2, FiO2, and you have to take all these cases on a case-by-case basis. Let's consider this first case where the baby has PPHN, your preductal SATs are 91, postductal 70, oxygen is 30%, and you have severe pH on echo. This is the term baby with PPHN, and you increase your oxygen. Oxygen is a powerful vasodilator. You increase your preductal saturation, which should be a target saturation, and the risk of hypoxic pulmonary vasoconstriction outweighs risk of oxygen toxicity. Whereas on the other case, if you have infant with CDH, where there's secondary pulmonary hypertension, you might have preductal saturation in 90s, you have a normal lactate, no acidosis. If your oxygen is 80%, you closely monitor these cases, and so your risk of oxygen toxicity outweighs risk of hypoxic pulmonary vasoconstriction. So you always try to balance, it's a balancing act in all these cases and how to manage them. So next is, how do you optimize your hemodynamic status after you have recruited your lung, you have optimized your FiO2 and PaO2, and how do you optimize and tease out whether it's RV driven, LV driven, or biventricular. So there are a couple of drugs which can act in combination with nitric oxide, and we'll come to it in detail, which is sildenafil, which works through the cyclic GMP pathway by inhibiting phosphodiesterase E5, and it can have an additive effect with nitric oxide. It has a nitric oxide sparing effect. You could wean the nitric oxide once sildenafil reaches steady state levels. There are few conditions which do not respond to nitric, where I'll come to it. You could have remodeled pulmonary vasculature, where classic example in CDH, if you have LV hypoplasia, left ventricle is hypoplastic and dysfunction, these babies may actually have harm after initiation of nitric. If you have alveolar capillary dysplasia, where these patients would be nitric responsive, and prematurity in some babies, in preterm babies, where you have long-standing oligohydramnios leading to pulmonary hypoplasia, these babies might not respond to nitric and might not be nitric responders. So nitric responder versus non-responder, always try to tease out, is your pathology on the right side of the heart or the left side of the heart, or is it in the pulmonary capillaries, or is it in the lungs, and at what level the problem is. And if you can identify that at the bedside with all the history, all the cues which you have, then it will help you narrow your diagnosis and give tailored therapy to these cases. So the cases which have a degree of pulmonary hypoplasia could be seen with prolonged rupture of membranes, renal malformation, polycystic kidney disease, renal agenesis, which can lead to oligoanhydramnios sequence leading to pulmonary hypoplasia. It can also be seen in masses in the chest like CDH, CCAM. So all these cases, yeah, the pulmonary hypertension is quite tenuous and difficult to manage. And if you have cases due to disordered transition such as Meckel syndrome, RDS, pneumonia, many of these cases could be nitric oxide responders. You could have cases originating from the right side of the heart due to increased pulmonary overcirculation due to left to right shunt. And lastly, the LV phenotype, which could lead to pulmonary venous hypertension and pulmonary edema, and what we discussed as post-capillary type. There are few conditions which we'll come to it later, which can worsen after iNO, which is LV dysfunction, which can happen either in secondary cases after CDH, asphyxia, sepsis, or post-cardiac arrest, or you could have LV hypoplasia and critical congenital heart disease. You could also have worsening after iNO in obstructive AVR. So what happens in this? Nitric oxide dilates your pulmonary artery and floods the lungs with more blood flow, and it almost kind of diverts all the flow to the lungs and decreases your post-PDA systemic blood flow. So you have worsening shock status and worsening end organ function, and you have your lungs getting more and more pulmonary blood flow, which can lead to pulmonary edema. Secondary, baby is dysfunctional. As you can see here, your can be transmitted to your pulmonary veins, and that can cause pulmonary edema. Lastly, prematurity and iNO is a big controversy in North America because trials done early on have shown that there is a non-significant increase in IVH, but there are more and more database studies which have shown that babies or preterm who receive iNO, they definitely improve survival if they respond, if they are responders. And so there are few phenotypes which would respond, and the phenotype which I've discussed earlier is the preterm prolonged rupture of membranes. These are the babies where they could be nitric oxide responders. So what is iNO resistance? Moving on to the second part of the talk. If you don't have any improvement in your oxygenation indices within 30 to 60 minutes, so within an hour of initiation of iNO of 20 parts per million, and if you don't have improvement in oxygenation indices, many trials have 20% improvement in your OI, OSI, PaO2s, PaO2 FiO2 ratio, whatever indices you use. But if you don't have improvement within an hour, then those babies are labeled as non-responders. The incidence of iNO non-responders ranges from 21 to 37% in term babies. In preterm babies has been reported to be between 18 to 44%. There are few few studies which have looked at and which have implicated meconium aspiration syndrome, HIE, and RDS as clinical predictors of iron non-response. And there are few evolving echo predictors of iron non-response. There are only 3 studies have looked at it closely. Adrian Bishop from Iowa, when she had looked at the cohort from Toronto, lower LV global strain and moderate to severe RV dysfunction at the onset of the illness, if you have it, those are the babies who might have iron non-response. Study by Malowitz looked at lower tricuspid annular plane systolic excursion. So basically, how the tricuspid valve moves from base to apex. If you have a lower value, and if you have lower right ventricular uh, global longitudinal peak strain or shunting across your PDA, if it is purely right to left, these babies had higher need of ECMO on that. And a very recent study which had looked at eccentricity index of left ventricle, and if you had a higher value on presentation, then you had a higher likelihood of need for ECMO. So this was a case which I still recollect when I was a trainee doing my hemodynamic fellowship. You had a typical case of a term infant delivered by a C-section with thick meconium stain liquor, poor Apgar scores, abysmal cord gases, heart rate of 84, this baby being cooled, and you had a blood pressure which was on the lower side, 46/30, means of 35. But this baby was on minimal event settings, PEEP of 7, FID of 25 to 30%. And when I put my probe and did the apical 4-chamber view, you can clearly see your right atrium and right ventricle is not contracting well. You have poor contractility, you have ballooned out right atrium and quite dilated, and you can almost see the interventricular septum bulging into your L. And that led to me thinking, as a trainee, why is RV always the first to take the hit in these cases with PPHN? RV has a unique anatomical configuration. It's crescent shape with a large circumferential radius to wall thickness ratio. So it's more vulnerable to wall stress compared to LV. It's more metabolically active. It's a dominant ventricle during transition. And its coronary flow is vulnerable because coronary flow through your right coronary artery can reduce if you have increased central venous pressure, and if you have low diastolic pressure or low aortic. RV is usually, in most cases, the first ventricle to be affected. So I would encourage the trainees to pay attention now, because this is the next few slides are very interesting. So isolated RV dysfunction can happen in HIE, meconium, sepsis, RDS. And if you have high pulmonary vascular resistance due to abnormal transition, then what can happen? Your RV will slowly dilate and will become dysfunctional. If your RV is not pumping blood adequately and has poor systolic function, can lead to low pulmonary blood flow. Low pulmonary blood flow can lead to low LV preload, and ultimately the heart can compensate to a certain degree, but can lead to low left ventricle output and lead to shock. So how do you manage these cases? You support the RV systolic performance with an iNO probe, and you reduce your PVR, and the drug of choice is inhaled nitric oxide. Isolated LV dysfunction, we have seen many a times in enteroviral sepsis, herpes simplex, in HIE. Also, it's well documented in congenital diaphragmatic hernia. So let's divide it into systolic impairment. If it causes decreased contractility, as we discussed, it can lead to shock. But if there is decreased relaxation or diastolic impairment, it can lead to increased LA pressure, and which can lead to increased pulmonary venous pressure, which can lead to pulmonary edema and decreased compliance, and which can lead to hypoxia and impaired ventilation. So, as you can see in the echocardiographic image here, the LV is barely moving. It has a circumferential contraction moment, and it is, if you do the biplane measurements here, it would definitely be moderate to severe dysfunction. So managing LV dysfunction cases are very challenging. You support your LV systolic performance by giving an iNO like epinephrine. You optimize your mean airway pressure because your lungs are very wet and has pulmonary edema. So you have to increase your mean airway pressure to open up the lungs again. You may have to give diuretics, and if your ductus is small and restrictive, you might have to give prostaglandin to keep the ductus open, because your right ventricle, as in this case, is healthy and normally function, and that can support your systemic circulation. And the most difficult of all these cases is biventricular dysfunction. And you could have it in HIE, meconium, viral infections, where you could have a lot of pathologies happening at the same time, increased PVR leading to right to left shunt across PD and PFO, leading to decreased pulmonary blood flow as we saw, and that leading to decreased LV preload. But in tandem, if you have decreased SVR, then you'll have reduced coronary perfusion pressure, which can lead to both ventricles getting affected. And I'll come to it why both these ventricles work in complete symbiosis, and if one becomes dysfunctional, the second can also have some problems, and that can ultimately lead to shock or acidotic state. So this is a case where both the ventricles are dysfunctional, and these babies can be very sick, and they can deteriorate really rapidly and may need a robust dose to increase systolic performance. It's tricky because you don't know which is the dominant ventricle which is affected. So you may have to reduce PVR if it's right-sided, and you may have to reverse PVR SVR axis. So RV and LV, they have ventricular-ventricular interactions. There is mechanical coupling due to shared cardiomyocytes, interventricular septum. You have circuit in series, you have neurohormonal coupling, and you have electromechanical coupling. So if you have one ventricle which is affected with time, because the another ventricle will also be having due to VV interactions. This is a unique, interesting cases. We could have normal function with increased PVR, and you could see this in GBS pneumonia, prolonged PPROM, renal anomalies. So if you have severe oligoanhydramnios, you have pulmonary hyperplasia, which can lead to muscularization of small pulmonary arteries, leading to vascular remodeling, leading to increased PVR. And as you can see in these cases, this is a apical four-chamber view. You have biventricular hypertrophy, good function, but when you look at your ductal view, you have bidirectional flow through an open ductus. You have blue and red jet flow, which is seen in the Doppler pattern also. So these cases, it's important to reduce your PVR, and if they are non-nitric responders, you might need additional therapeutics. There are few cases such as hypertrophic cardiomyopathy, which is seen in infant of diabetic mother. Sometimes there could be some genetic metabolic conditions or congenital hyperinsulinism. These can lead to interesting case where you might have significant biventricular hypertrophy with an asymmetric septal hypertrophy. So these cases, no agent which works on adrenergic receptors, inotropes will work. These babies, if they present with shock or pulmonary hypertension, the only way to fix the problem is to give fluids to increase your preload, and which will, and secondly, use vasopressin, which does not work on alpha beta receptors. It works on V1, V2, V3 receptors to increase your SVR, to increase your blood pressure. So very interesting cases. So avoid inotropes, avoid increase in heart rate, optimize preload with fluids, and increase SVR. Vein of Galen malformation or large AVMs, these states which can lead to fluent pH, either through RV dysfunction or through hypoxic respiratory failure. You could see dilated because there is excess amount of blood coming to your right side of the heart through the vein of Galen malformation. You could have dilated RARV. You could almost see the interatrial septum bulging into your LA, and you have PFO, which is right to left predominantly, and you would have a lot of blood almost getting stolen. You could see this regurgitated aortic regurgitation, the blood which is going to your transverse aortic arch to your uh, first branch of air. So these cases, you support your RV-LV systolic function with an inotrope. If the patient has features of hypoxic respiratory failure with FiO2, not just echo features, but if FiO2 is more than 80%, you reduce your PVR, but the goal is early embolization of these patients. Congenital diaphragmatic hernia is, I always say it's Dr. Hyde and Mr. Jekyll, is a dynamic clinical phenotype. You could have either normal cardiac function with mild or no pH, where just lung protective strategies is the key strategy. Or if you have RV dysfunction with significant pH, you keep the PDA open and reduce PVR. If you have biventricular dysfunction, again, maintain your PDA open and avoid excessive afterload. So no norepi or vasopressin, which can increase your SVR. LV dysfunction, the same principles as how we manage LV dysfunction cases. In preterm babies, sometimes we could have post-ligation cardiac syndrome or post-transcatheter cardiac syndrome, where you have very dilated LALV, large PDA, and undergoes a PDA ligation or PDA device closure. And after a few hours later, you could see because of increase in afterload, the LV is not contracting properly, and you have LV systolic dysfunction plus or minus LV diastolic dysfunction. So there are three phenotypes of neonatal pulmonary hypertension. If it's driven through PVR, iNO is usually effective. If it's driven through flow, iNO can increase your pulmonary blood flow further because it's dilating your pulmonary artery and increasing pulmonary blood flow. And in the post-capillary phenotype, in cases of LV dysfunction, either due to a congenital heart disease or due to a secondary cause, iNO can actually worsen your pulmonary edema and worsen your shock, and is usually relatively contraindicated in those cases. So how do we manage these cases? In interest of time, I'll be a bit quick. So we'll look at respiratory management. We always have to optimize alveolar recruitment, which will increase VQ matching, increase ventilation. How do you optimize alveolar recruitment? You could increase your mean airway pressure due to incremental increase in your PEEP or MAP. If you have a jet ventilator, you can use side breaths. How do you evaluate whether what you are doing at the bedside is helping the patient? In conventional ventilation, pressure volume loops are a good source, but there are newer mechanisms which have not still prime time in new ones, such as transpulmonary pressure monitoring. Lung ultrasound is still an investigational modality. So how does what's the relationship between PVR and lung volume? So the interesting physiological concept. If your PVR, if your lung volume is if your alveoli are hyper expanded, then your lung volume will move towards your TLC, and you will have increased alveolar PVR. It's a U-shaped relationship due to external compression, as you can see in this figure. And if you move towards atelectasis or under-recruited lung, then you move towards residual volume. You have raised PVR due to kink vessels. And so you want to be in the FRC state to have your PVR at your lowest, either on both end of the spectrum, you might have high PVR, and so it's always important to not overdo or be overzealous with your mean airway pressure, and increase your PEEP or your mean airway pressure, your HFO by 1, uh, and see what's the response, and slowly go up. And when your oxygen saturation improves and remains stable, that might be the critical pressure. There is one trial by Gonzalez which looked at the combination of surfactant and iNO is better than control in iNO. And there were lesser treatment failure rates, lesser rates of ECMO death. And there is the Kinsella trial of nitric oxide, which was a multi-center trial where nitric oxide was given to babies who were more than 34 weeks. And they were stratified into disease categories. 70 babies had RDS, 58 had meconium aspiration syndrome, and the rest, 43, had other causes, and 34 had congenital diaphragmatic puncture. So what this trial showed us that HFO plus iNO is synergistic in babies who had parenchymal lung disease. The black bar is the combination of HFO and iNO, significantly better than HFO alone or iNO alone in meconium aspiration syndrome and in RDS also. And in other cases, such as idiopathic pulmonary hypertension, there was no difference between HFO plus iNO versus iNO alone. So HFO plus iNO is if you have your underlying mechanism or your disease pathology, meconium, aspiration, or RDS, it is synergistic, well seen from this trial. Supportive strategies are important. Stress, pain, agitation can lead to increase in PVR through release of catecholamines, increase in your oxygen consumption. It can interfere with mechanical ventilation. So we always advocate for these non-pharmacological measures at the bedside, lower light levels, use like iPad and ear muffs, facilitated tuck, always cluster your cares to Q4 or Q6, minimize or cluster painful and diagnostic procedures. There is a role of sedation and muscle relaxation in PPHN because of all the reasons which we just saw. And you want to increase your lung compliance, reduce asynchrony, facilitate prone positioning, and minimize self-induced lung injury. So it is a cornerstone of managing these patients. And there is no magic bullet as to which drugs you should use. You could use a combination of drugs. Commonly at seconds, we use, if the baby have low blood pressure, we use fentanyl, and for muscle relaxation, we either use rocuronium infusion, but we use an infusion. Moving on to the last aspect of the talk, to what are the pulmonary vasodilators and how do we decide at the bedside among the sea of agents as to what agent do we need to use. Nitric oxide works through the CGMP pathway causing vasodilatation. Sildenafil through inhibition of phosphodiesterase 5 also works through CGMP. On the other hand, the CAMP pathway is either through all the prostaglandin analogs or through milrinone, and it increases CAMP levels, which causes vasodilatation. Another agent which is used in adults and in pediatrics is bosentan, endothelin A receptor inhibition, which is a powerful vasoconstrictor. So bosentan can cause pulmonary vasodilatation, but this drug is only available orally. So it has limited efficacy in acutely sick patients. So you have iNO-resistant pulmonary hypertension. You have gone through your ABCs, sedated the baby, given surfactant, optimize your MAP through your menstrual ventilation. You started iNO, pulmonary hypertension. The baby has not responded despite an hour of administering iNO. So how do you make a choice at the bedside, whether to give milrinone, sildenafil, or give Prostin? All evidence because there are just handful of trials assessing these agents, 9 patients in milrinone, a maximum in IV sildenafil, and none of them have shown any benefit, probably because they are underpowered and you need big numbers to show efficacy. So how do you make a judgment choice at the bedside? So let's start from the right heart, what we had addressed before. If your right heart is dysfunctional, you would have ultimately these patients can lead to low pulmonary blood flow and can lead to shock state. So you need to remember these 3 principles or these 3 pillars. How do you reduce your RV afterload because your PVR is so high? And you have to maintain your normal systemic blood pressure because that will perfuse your RV. If you have normal blood pressure, you'll have good perfusion pressure. And lastly, how do you improve the RV systolic performance? So always think what is happening at this point. Is it RV dysfunction? Is it RV dysfunction with shock? Is it RV dysfunction with normal blood pressure? And then try to give the therapy. So if you have RV systolic dysfunction or systemic hypotension, let's divide it into there's none or mild dysfunction and you have normal blood pressure, but you have a high FiO2 requirement. So you just decrease your PVR. If you have moderate to severe RV dysfunction or hypotension, so there could be 3 possibilities. You have normal RV with hypotension, you have RV dysfunction with hypotension, or you have RV dysfunction with normal V. Very confusing. Let's break it down. So if you have a hypotensive neonate in iNO-resistant pulmonary hypertension, what would be your drug of choice? And so on your slide, you have on your y-axis, you have change in your PVR-SVR ratio before versus after treatment. And as you can see, dopamine and epinephrine increases your PVR-SVR ratio. Your PVR needs to go down, your SVR needs to go up. So it does the reverse at those doses. It will have the opposite effect. There are 2 drugs which are in close contention with each other to increase your blood pressure is vasopressin or norepinephrine. Coming to, there's been a lot of chatter, this article where dopamine has been slammed in PS 2024 because it has a lot of bad effects. It causes increased pulmonary vasoconstriction, which increases your PVR, increases your RV afterload, and can lead to this downward spiral of inadequate end organ oxygen delivery. So if you have a patient who is in 90-100% oxygen, PH physiology, and if those babies are hypotensive, dopamine will actually cause harm than have any benefit. So when we look at the 4 agents, vasopressin, norepinephrine, dopamine, and dopamine has clearly taken a back seat, and we now need to tease which of these 3 agents would be optimal. Vasopressin has been shown in animal models as well as in newborns to have consistently to improve blood pressure. As you can see in this OLED study, it increases systolic, diastolic, and mean blood pressure. It does not work through your traditional alpha beta receptors. It works through V1, V2, V3 receptors. The study from Toronto, we looked when vasopressin was combined with iNO, your oxygen index significantly reduced over time, over the next 3 days to really low levels. There is increasing evidence, but again, low certainty of evidence because there are not many trials compared to standard treatment approach in support of vasopressin. Total published experience is 200 neonates, it's case series only. And the thing which puts off most neonatologists against using vasopressin is the fluid retention and moderate to severe hyponatremia with higher doses, especially in the cases with HIE, with the babies being pooled, the hyponatremia is quite significant. So, what is the starting dose? It's 0.3 milliunits per kilogram per minute, and you can go all the way to 2.5 milliunits. And every 20 to 30 minutes, you increase your dose by 0.3, 0.6, 0.9, 1.2, and see till you have effect and increase in your blood pressure. Norepinephrine, people would say that norepinephrine is equally good. It increases your SVR and may reduce your PVR too. There was a French study by Tornu where it reduces your pulmonary artery to systolic artery ratio. But these babies had moderate hypoxemia. Only around, these babies had oxygen requirement in 50%, plus or minus 20%. There are animal studies done by Satyan where there is pulmonary artery vasoconstriction in 100% oxygen with norepinephrine. And there are studies also in hemorrhagic shock in piglets where more evidence that norepinephrine may increase PVR over SVR, and vasopressin reverses that ratio. So if it's a battle between the two drugs, vasopressin has a little bit more evidence in support of it. Norepinephrine can reduce your PVR, SVR, but can also cause some inotropy and may not be the ideal agent if you have catecholamine resistance also. Next question is, which inotrope for ventricular dysfunction? So always think, if you have hypotension, you need to increase your SVR in PPHN. So the question would be, should you use vasopressin versus norepinephrine? And if you have ventricular dysfunction, echo features of poor RV, LV, or combined biventricular dysfunction, what would be your inotrope of choice? Among neonates with ino-resident pulmonary hypertension, milrinone has improves echocardiographic estimates of LV and RV systolic performance. The other two agents are low-dose epinephrine between 0.01 to 0.1. Limited data, again, limited data among neonates with PPH. So milrinone, in term babies, sometimes we give a loading dose, never in HIE patients. It's an lucitrope, so it causes inotropy, it reduces your afterload. But the problem with milrinone is it has a long half-life, and there has been 1 or 2 publications which have shown that when used in hypothermic patients, it significantly increases the risk of hypotension and may cause harm. Epinephrine low dose, it's a beta agonist and weak alpha agonist. The dose range is 0.01 to 0.1. Again, it's a potent inotrope amongst the 3 inotropes. You can never use milrinone if the baby is hypotensive. You need to have robust blood pressures because milrinone can reduce your systolic and diastolic pressures both. The problem with epinephrine is it can lead to hyperglycemia and hyperlactatemia, and these side effects are predominantly seen in HIE patients. Lastly, dobutamine, beta-1 agonist, the dose range is 5 to 20. Whoever has used dobutamine, it's a good inotrope, but it significantly causes tachycardia, more so in HIE patients. So, which is usually detrimental. You don't want the heart rate to just shoot up to 1. You need adequate time for myocardial relaxation. So coming back to our right heart phenotype, if you have a baby who has normal RV function with hypotension, and if you want to increase your blood pressure, vasopressin is the drug of choice. You may consider, based on the limited evidence available, norepinephrine if your FiO2 is less than 50%. Second line agent is hydrocortisone. If you have RV dysfunction with normal blood pressure, then the 3 drugs which I used are milrinone, low-dose epinephrine, or dobutamine. And if you, the worst scenario out of all these three, if you have moderate to severe RV dysfunction with hypotension, then you need to use class of each drug. You might have to use vasopressin and an agent to increase the systolic performance. I commonly use low dose epi with vaso because they belong to different class of drugs. And in these cases, if you have a small or a restrictive PDA and blood pressure, mild dysfunction, FIR is less than 50% are specific pulmonary vasodilators. We've talked about milrinone. I'll talk about IV sildenafil. Loading dose is 0.4 milligram per kilogram over 3 hours. Maintenance dose is 0.06. And bosentan, as said earlier, is an oral drug. None of the trials have shown any benefit, but again, very small numbers in these randomized trials till date. So if you have a baby who is on nitric, if your FIR is still about 60-70%, if you have done an echo, has normal blood pressure, none to mild dysfunction, you just need to reduce PVR by either using sildenafil or milrinone. Coming to your left heart, the goal in left heart failure or dysfunction is to increase your LV function. You need to reduce your LV afterload and you need to have normal systemic blood pressure so that you have adequate coronary performance. First, you need to stop iNO if you have isolated LV systolic dysfunction because iNO may cause harm, may worsen your pulmonary edema and worsen your end organ function. If you have normal to high blood pressure in LV systolic dysfunction, then you will be known as the drug of choice. If you have systemic hypotension, then epinephrine would be your drug of choice, and the second choice would be dobutamine. It increases your cardiac index and blood pressure. So to summarize, if you have a baby who has severe HRF, FIR2 more than 80%, pre-postductal SAT difference more than 10%, and suspected PPHN, the 5 steps of management: you intubate and mechanical ventilate, use HFO if your underlying disorder is meconium aspiration, pneumonia, RDS, a parenchymal lung disease problems. You might have a pneumothorax or an effusion. So you need to rule out those. Target optimal lung volumes. You don't want to be needed. Target CO2 levels and sedate plus or minus muscle relaxation. If these approaches are ineffective, use surfactant. Surfactant is class 2A recommendation in most of the parenchymal lung disease, except CDH. It actually causes harm in CDH, so not to be used there. And after that, you can give a trial of iNO and then decide if it's a non-responder. Echocardiography is warranted because you don't know whether it's PH or you're dealing with a critical congenital heart disease. With centers who have all the resources, I would advocate echocardiography much higher in this algorithm. But many of the attendees are from developing countries, and that's the reason echocardiography comes later. Inotropes and vasoactive agents. So to summarize, this is the golden slide where if you have a baby in right heart phenotype, if you just have none to mild dysfunction with normal blood pressure and the FIR is still more than 50%, you will give a trial of milrinone or sildenafil. If you have a baby who's more sicker, who either has normal RV with hypotension, then use vasopressin as a drug of choice. If you have both RV dysfunction and hypotension, you use a combination of agents. And if you have just RV dysfunction with normal blood pressure, then you use either milrinone or epinephrine based on your blood pressure. So in pulmonary hypertension, appraise the underlying physiology for acute pulmonary hypertension. always integrate your clinical lab and echo parameters, because you need to have the whole story and not just the echo piece. You need to have a good history, good examination findings, and your lab results to integrate this with your echo findings. Delineate your phenotype, what you're dealing with. Is it RV, LV, or both? And give early goal-directed targeted therapy that will help you deliver individualized iron non-response with acute PH is relative HI and sepsis, echo markers of RV dysfunction, right to left shunt across PDA, some of the surrogate markers of iron non-response and need for ECMO. Iron non-responder PH is a medical emergency. And I always say, identify your correct phenotype, institute the right therapy at the right time with the right end goal is key. You cannot relax in these cases. You have to be on top of it, because if you let hours go by, might have helped me out in my journey, and I'm open to have questions.
Thank you so much, Dr. Bonny. Now, may I request the moderators to open the house and begin the deliberations.
Yeah. Thank you so much, Dr. Bonny. It was lucid and elaborative talk covering everything about iron-resistant pulmonary hypertension, all the spectrums, and the how to direct a pathophysiology-based treatment. So we have few questions in QA. Before that, I have two quick questions. May I?
Yeah, sure.
Yeah.
Go on, Rahul.
So, yeah. Any experience with nebulized iloprost as a adjunct to iNO?
Nebulized?
PGI2.
No. We are maybe PIs has some experience, but I don't have any newborns.
What about Bosentan? I mean, do you people? I mean,
we use Bosentan in chronic PH. Babies who are recovering from congenital diaphragmatic hernia, way down, like few months down, and still has pulmonary hypertension, for transitioning home. And second would be 24, 25 weekers who are like 42 weeks, has pulmonary hypertension secondary to BPD. Those are the cases where we prefer Bosentan over sildenafil.
Do you use muscle relaxants for all the babies on, say, HFO with stiff settings?
Not necessarily. So we give 2 hours to put in, get the tube in, get to HFO, give surfactant, put lines, get the first set of blood work, and start nitring. And if the baby is not responding and has really poor blood gases and overall picture, then we give very few hours to see if the baby is turning around the corner. If not, then we start muscle relaxation. We start rocuronium infusion. 4 to 10 is the dose range. So we start somewhere in middle. But we first sedate the patient, get good sedation on board, and only then muscle.
So I'll just start with few questions. I mean, the first question is like, do you consider milrinone despite hypotension from LV dysfunction?
Never. If you hypotension, never, in uppercase letters, use milrinone.
Dr. Anita, can you take over? I think my network is not good.
Uh, I think Dr. Bonny's network is not okay,
Okay,
and
okay. I am
uh,
not able to hear him.
he got probably disconnected as well. So we can wait till he rejoins, and we can just discuss the questions in the chat box. So first one was that would we consider milrinone despite hypotension from LV dysfunction? So it was a big no. It was put in the presentation as well, and Dr. Bonny also suggested the same. So subsequently, another question is that when we have LV dysfunction, we should we wait for dysfunction to improve before trying to decrease the PVR, and how it would be guided? Probably that Dr. Bharat is like would like to ask for. So he is asking how frequently one should keep on repeating echoes to guide the judgment about initiating the pulmonary vasodilators and looking at the SVRs. So Dr.
Yeah.
Rahul would comment on it, right? Like
Yeah, I was
how
just reading the question. It's too big. I'm trying to understand. So basically,
basically, it is like in case of a resistant pulmonary hypertension, before targeting the therapy according to the phenotype, how frequently one should be guided by echo. So, how frequently one should have to go for the repeating echo. So, I
yeah,
think there cannot be a single answer about the frequency of echo. It can be as frequently as 15 minutes as well, or it could be every 2 hours as well. That depends on the criticality, your oxygen levels, and need for the FiO2s. So it all depends on the lung recruitment and what we are doing for the decreasing the LV dysfunction.
yeah,
Then other thing has been asked whether the as under recruitment or over distension both are worsens the pulmonary hypertension, and that's quite evident that we have to optimize the lung inflation. It should be neither underinflated or overinflated. So he's asking that, do you agree to ideal map to recruit maximum lungs should be not fiddled with till other variables have been weaned off? So it's quite evident that it's not just one lung recruitment we have to focus upon. It is a comprehensive management of the baby, and one should look for so many things like what is the temperature of the baby, what is the perfusion of the baby before just pushing the map button and recruiting the PEEP and increasing it higher in desperation to get the sats within the normal range. So that's it. It's always a comprehensive management. It should be not just obsessed on the lung recruitment. Although the key for the pulmonary hypertension management would be like lung recruitment, pulmonary vasodilator, decreasing, looking for the SVR, but then simultaneously one has to also look for the other things. So experience of using magnesium sulfate as a vasodilator, I don't think anybody do use, and it hardly works. And even if it can be done in cases where you can be pushed against the wall, you can just use it once. Increase levels of the magnesium by repeated doses can be harmful even. So it's quite a doubtful thing to do, and it is not evidence based. There are anecdotal reports which has not been coming up in last 1 decade. There were use of magnesium sulfate was considered way back in 2000s, I suppose. So
Sorry.
I think Dr. Bonny is here again.
Yeah. Sorry, my internet.
not a problem.
So we will quickly take the questions, Dr. Bonny, and it was first was that regarding the use of milrinone in
Yeah,
case of
sure.
hypertension. So it was a big no that it should not be used in case of hypertension. And subsequently, somebody has asked that whenever there is LV dysfunction along with the pulmonary hypertension, one should address the uh, decreasing the SVR first and then trying to decrease the PVR. So for judging that, how frequently one should do the echoes, and what should be the time to start iNO or other pulmonary dilators in the deciding.
So we do
That's
echo only. Yeah. So the question is how frequently we should do echoes in these cases. So let's consider a case with a non-nitric responder. We got an echo. We say, oh, the pressures are suprasystemic, RBSP of 80, bidirectional flow across PD and PFO. So that would be the first echo. We'll start all the therapy. If there's RV dysfunction, we'll start epi. If the blood pressure is low, we'll start vaso. We'll start both the agents together. And if the baby is not improving with the first line therapy, then we would repeat the echo. Rarely that happens. These babies always respond at a different dose for different patients. So we usually do echoes once a day, not very frequently, like 12 to 24 hours, unless these patients are so sick that we have to refer for ECMO.
Okay, so another question is that underinflation and overdistension both are harmful and worsen the pulmonary hypertension. So, what should be the ideal map to recruit lung volume, and should not be, and it should, whether it should be fiddled with till the other variables have been weaned off.
So if you
So
are
what-
on conventional,
Yes.
if you're on conventional ventilation, you have pressure volume loops. If you have beaking on pressure volume loops, you are over distended. Or if your pressure volume loop is not a nice leaf, like opened up structure, very close to each other, then you have decreased compliance. So you always have to titrate your PEEP based on these loops and based on X-rays and all other information. There's no magic number. Babies. And if you're needing mean airway pressure about 12, 13, 14, we switch to HFO. Because in HFO, MAP and amplitude are decoupled. You can independently titrate both the agent, both the norms. So yeah.
There is one query regarding experience of using magnesium sulfate as vasodilator in case of PPHN.
So there's a lot of evidence about magnesium sulfate only from India because we didn't have iNO for the longest time. The trial was from Kashmir by Dr. Bhatt. It was published in pediatrics and had shown reasonably good results. If you don't have iNO, it's a good agent. But again, magnesium sulfate, like all other pulmonary vasodilators, milrinone, sildenafil, they all cause low blood pressure. So you might have to keep a background infusion of norepi-vaso running to titrate your blood pressure to keep it in the normal range. You don't want to decrease PVR, but also decrease SVR at the same time.
And then it can be done as a single or two doses, but one or two doses, because repeated administration may not be possible.
Right.
So
I don't know if sildenafil is available in India IV form, but we have had a lot of good results with sildenafil, specifically with the regimen which I had noted in the talk. And within 4 to 8 hours, the babies respond and the oxygenation index and FIR2 comes down.
So Dr. Rahul can take further questions.
So there's a question, Dr. Bonny, basically it is being asked like there is no facility to do a functional echo in the unit, and they face iron resistance.
Sure, it is. I have a good bedside clue how to manage without echo. Let's consider a patient whose pre-ductal is 85, post-ductal is 60, and your difference is 25, and the patient is hypotensive. So you know that this patient's PVR is very high and your SVR is low. So you need to, how do you know that? Because you have a big difference in your pre and post-ductal SATs. Pre-ductal SATs are essentially blood flow from the upper part of the body. Post-ductal SATs are whatever is in your lower half of the body. So if you have a wide pre-post-ductal SAT difference, it means that you have a wide open duct and a lot of the blood is being shunted right to left to the cardiac side. So how do you reverse this? You can reverse this by increasing your blood pressure and decreasing your PVR. How do you decrease PVR with iron, which is which you don't have. So you could increase your blood pressure, and as your blood pressure improves, you would see that your pre-postductal SAT difference is slowly narrowing down and your oxygenation is improving. Uh, Once it becomes absolutely pre and postductal SAT difference is less than 5, that is the point, that is the sweet spot. Once you achieve that at the bedside, your FiO2 will be down 100%. So
So,
always easy approach. If you don't have echo, start epi plus vaso, middle dose of epi 0.05 and vaso start with 0.3 and start titrating your vaso to get your blood pressure above your 50th centile. Or like a good, like for a term baby, get your means above 55. Uh, and you could see at the bedside, as you are doing that, your P and postductal will slowly become more and more smaller, and your SATs will improve as well as your FiO2 will come. All these things will happen in tandem.
so the next question is there a difference in the management of RV systolic or diastolic dysfunction in pulmonary hypertension? Whether the treatment changes for systolic or diastolic?
No,
Same.
there are no markers, echo markers to measure which are validated for RV diastolic risk. All the echo markers so far what we calculate TAPC, FAC, RVO, they're all systolic markers for systolic function.
Yeah. When to consider surfactant in pulmonary hypertension? Any specific criteria?
So good question. Is the advent of HFO, the use of surfactant has gone down. If you have a meconium aspiration or an RDS in a term baby or a bad pneumonia case, so in those cases, do your ABCs, intubate, sedate, put your lines in, and transition to HFO. See what's the response. If you're still needing very high oxygen, above 60%, if your PO2 is still poor, if your X-rays and gases have not improved, then you may consider something. And again, a practical consideration is if it's a big baby, a 4-kilo baby, then you can't give Survanta, like it would be 20 mils, right? So then maybe Curosaf would be a smaller dose, better tolerated by these patients compared to, what do we say? Bless is Neosaf, right? In India? Bless, no, it's not
Yes,
Bless.
yes,
Bless.
it is Neosaf. Yes.
So both are 4 and 5 mils per kilo. Compared to that, Curosaf is a smaller dose, smaller volume.
The next question is how do we decide on the target blood pressure? Whether it is based on the TR jet, probably TR means for TR jet, maybe.
It's a good question and a tough question. So usually ballpark figure, we have instituted 50th, 95th, and 3rd centile for various post-menstrual ages. We have charts in our unit and they're available. So we know what are the 50th centile for what gestation. But if you don't have that, then you just, like if it's a term baby, so 40 would, let's consider 40 weeker, then at least minimum 5 above your gestational age. So at least it should be above 45 and above. So for a term baby. But
Yeah.
it could be higher, as you said. If your RVSP is 80, 45 won't be enough. You would need it to be higher. So you need to have an RVSP value to guide you, but also you need to keep the blood pressure more robust. As I said, means about 55 and above, usually we can manage these cases.
There's one more question like the case scenario, what we discussed, the echo is not available. There's no iNO as well. The blood pressures are normal. So instead of EP and vasopressin combination, can we use milrinone?
Yeah. So if your blood pressure is normal and you don't have hypotension, milrinone is a good agent. You start with a middle dose 0.5 microgram per kilogram per minute, and the baby will be fixed by daytime, like in next 8-12 months. It's a slow acting drug, so it won't be very quick. Like, so don't lose patience because it will take 6 to 8 hours for the baby, for the drug to reach steady state levels.
We don't have any more questions in the Q&A box. Okay. We are done with the questions.
If you guys have any questions, reach out to me on my sick kids address. I have a lot of resources. We have drafted guidelines for our unit for all these varied combinations because we get a lot of non-nitric responders and our ECMO utilization rate. I have not purposefully put ECMO because those are very low in our unit. It's almost 2 to 3%.
I have a question, Dr. Bonny. Like in cases of pulmonary vein obstruction, stenosis, how to identify it? Because it is often it is increasingly being recognized in extremely low birth weight babies, in
Right.
BPD especially.
So every extreme prem baby should get an echo at 36 weeks to screen for chronic pulmonary hypertension. And in that echo, they need to scan all the 4 pulmonary veins. High risk factors are surgical necrotizing enterocolitis. Those are the babies we have seen an uptake of pulmonary vein stenosis. So unless you Doppler the pulmonary veins, you would never know that the vein is stenosis. So you have to do pulse wave Doppler and you would see that there is a gradient in some of the veins. How do you treat it? We cause pulmonary vein dilatation in the echo lab. It's a very challenging procedure in the cath lab, sorry, done by interventional cardiologist. Even like in the best of hands, the success is low. So the mortality is high. But if you screen for them early, you would be able to detect early and then closely follow up. If
So
only
one thing is,
yeah,
yes, yes.
only one vein is stenosed, the 3 can manage this patient and these patients can go home. But if one on each side are stenosed, then it becomes a little tricky and these patients may need help.
Okay. So one thing you said that one is like a screening protocol or strategy to look for this baby at 36 weeks PMA. And in case of respiratory deterioration, one should have a suspicion of it and try looking for the pulmonary vein Dopplers to look for it. And if it is there, then prognosis is not good because intervention is the only choice.
It's only if your baby is in room and in 36 weeks, you should not screen. Like if the baby is 36 weeks and on moderate respiratory support, then you should have that screening criteria.
Thank you so much, Dr. Bonny, and thank you so much.
Thank you, Dr.
I request Manoj sir to have concluding remarks.
Well, it was a very comprehensive coverage, as remarked by some of the panelists, taking us from the physiology to the pathophysiology and then linking with the various management challenges. Thank you so much, Dr. Bonny. And this is a topic that we continue to discuss, and every time there are newer insights. If I remember correctly, this is the 4th lecture in our series itself on the on PPHN. So anyway, I mean, like thank you so much. It was an eye-opening presentation in so many ways. I would like to also thank the moderators for having moderated this session so very well. And finally, thank you, respected attendees, for having attended today. Looking forward to seeing you in our future presentations as well. Thank you.
Thank you, everyone. Thanks again.
Thank you. Bye.